So now on to our presentations. Our first presentation will be from Dr. Peter Blake. He will be sharing about patient-focused PD prescriptions. I'm looking forward to suggestions from him as we strive to make PD patient-centered and a doable and effective part of our patients' lives. Peter Blake is a professor of medicine and former chair of the Division of Nephrology at Western University and a staff nephrologist at London Health Sciences Centre. He is provincial medical director of the Ontario Renal Network. He is former editor-in-chief of Peritoneal Dialysis International and former president of the North American chapter of International Society of Peritoneal Dialysis. He has a long-standing research and educational interest in chronic dialysis and has published and lectured widely in this field. Just a reminder that after Dr. Blake's presentation, there will be time for questions. Please save them until the end of the presentation. The screen is yours, Dr. Blake.
Thank you. Thank you, Naomi. And I'm looking to see, has my screen appeared?
Yes, it has.
Okay. I can't see it for some reason, but I can fix that. Okay. Look, first of all, thank you very much for inviting me to speak to the BC Renal Group. I have always had a great admiration for what BC has done in this area. I'm very involved with the Renal Network in Ontario, and we are mindful that we have much of what we do has been modeled on what was done in BC and what is being done in BC. So it's a pleasure to be here. So a couple of disclosures, you've mentioned one, and I'm also supposed to disclose that occasionally I do talks for Baxter Global. But I'm not a consultant, and I can say PD prescription and some of the changes in the general thinking about this in recent times. And I'm going to use case histories to demonstrate the clinical points that I'll make, and I hope that I'll get some feedback. Let me sort of stand back a bit first. When you're making a plan for a patient in any area of healthcare, you've got a couple of things to keep in mind. Three I list here: evidence-based medicine, which is often lacking in renal. We have some evidence, but not always everything. Cost, which we always have to think about because every healthcare system is constrained. But very important and very much emphasized nowadays is what the patient wants. The patient's view is getting much more attention, and appropriately so, than it used to. And that is, of course, the essence of patient-centered care. So let's briefly look at the evidence. This won't take long. When it comes to PD, it's fairly limited, even though we make a big fuss about it. The big clearance studies done in PD, the most famous is this one almost 20 years ago called Adamex, showed that giving high clearance didn't benefit patients' outcomes. And to some extent, that liberated us a little bit from using very high clearance prescriptions. And it was confirmed by a study done shortly afterwards in Hong Kong, where there was really no significant difference in patient survival between people getting standard versus high clearances. Doesn't mean clearance is not important, but there isn't a huge amount of evidence to suggest high clearance targets. We have learned some other things, that icodextrin solutions are of some help with volume-related endpoints, things like the patient volume status, the left ventricle, also with some metabolic issues like glycated hemoglobin and lipids. No study has shown that icodextrin makes people live longer. No study's ever been powered to do that. So we have some evidence in favor of icodextrin, but it wouldn't exactly be at the highest level. In the past, we've had a KT&V target in various bodies, KDOQI, ISPD, the Canadian Society, of 1.7 a week. But we've always recognized, I hope, that the evidence is modest and that when you're prescribing, you take other factors into account. Recently, the ISPD had a committee set up in 2019, 2020, led by Dr. Edwina Brown from the UK. I was fortunate to be a member of that. And one of the consensus points coming out of it is that goal-directed, high-quality dialysis is in, and so-called adequacy of dialysis, and that's KT and V, and especially KT and V in isolation from everything else, is out. And that's consistent with what KDIGO, the big international deadline or guideline grouping, said in 2019 on dialysis in general, that we had to pay more attention to other things and take a more balanced approach to KDIGO. And simultaneously, we have patient initiatives on various parts of renal, and one of them led by a group called SONG, which is patient-oriented, contains many patients. And SONG PD say that what matters particularly to patients is the ability to participate in life. Well, that makes a whole lot of sense to me for sure. But think of that as we go through the cases today. Life participation is every bit as important as clearance levels and phosphate levels and so on. So this is the document that came out of that ISPD work group, and it's published in PDI at the start of 2020. And basically, it focuses on shared decision-making with patients, awareness that patients' goals are not all the same, that they may differ, symptoms, well-being, quality of life, and treatment burden are important. So is clearance, but so is volume status, nutrition, residual function. The message is keep it balanced, give each their own level of importance for each case. And the idea that clearance goals for somebody with a very short life expectancy might be different for somebody who might be on the transplant list and might hope to live for 30 years. You just have to get the balance a little different, and you need to discuss it with the person. We all know what person-centered care is nowadays. I think it came to renal a little late, but I think it's coming now with a high impact. It's become a dominant idea, and of course it requires us all as care providers to be unbiased, not manipulating people to do the therapy the way we want, but taking into account what they want, their preferences and values, their cultural background, their social situation, whatever matters to them. In short, it's what I'd want, and I suspect what you'd want if you were receiving care of any type, whether it's from renal or any other area of healthcare. The essence is shared decision-making, the pinnacle of patient-centered care, as the New England Journal of Medicine put it a decade ago. So how does all this apply to peritoneal dialysis? Well, the first thing to say is we deal with a group of patients who on average, and we have to individualize, but on average have a lot of issues. They are socioeconomically disadvantaged to a disproportionate degree. They have limited life expectancy. They have major burden of disease. Dialysis is only part of the story for many of them. They have, sadly, a very impaired quality of life. That's been measured frequently. There's lots of exceptions, but on average, it's true. And some of them, many of them perhaps, value quality of life as much as quantity of life. That's often a difficult conversation to have, but they often vote with their feet and their actions and tell you that this quality of life matters sometimes more than quantity. I sometimes like to think of people as falling into a number of categories in dialysis. Again, this is an approximation. We have one group, the healthiest of our patients, who are on a transplant trajectory. They perhaps represent a quarter of the patients on a good day. The focus there, obviously, survival, long-term survival is very possible. And to some extent, that's the focus. And you'll maybe do things, expect more of them in terms of what you'll encourage them to do over issues like quality of life. At the other end, you have the people who are doing dialysis but are clearly frail often, the short life expectancy, a semi-palliative trajectory perhaps, where the quality of their life, of the time that's left to them, may be a little bit more important than what their phosphate level or their volume status is. And in between, you have a majority of the patients who are not going to get a transplant, but have some hope of living for some years on dialysis. And you want to focus on both quality of life and survival. I think it helps to see people in those terms and often to discuss the issues with them, though it can be a little uncomfortable sometimes, and with their families in those terms. So we're going to go through some cases here, but the message is that the patient should be participating in the prescription of PD. We should stop doing it in a formulaic manner. And I'll focus on things like incremental PD, low intensity PD, glucose sparing PD, as distinct from KT and V oriented PD. So let's start with a relatively easy one, perhaps. This is a 52-year-old woman, starts cycler PD. She's polycystic, 60 kilos, average transport. She's on a pretty standard regimen, 5 2-liter cycles at night and a 2-liter day dwell. And after 3 months, you do measure that KT and V, and she looks great. By any standards, she's dialyzed very well. But you'll note it's a mix of peritoneal and residual renal function. And she feels well, and her volume status is good. And she's somebody who's aware of what's going on in the field, and she asks you, can she skip the daytime dwell? She's heard that some people go without it. And could she go day dry? Because she's got a lot of residual function. So this is what she means. She wants to go from the sort of prescription on the bottom line to the one on the top line. And if this is a PD audience, you'll be very familiar with these sort of prescriptions. So I often present this when I'm teaching as a choice, and I give you 4 choices. Bad idea, you can't get enough dialysis, can't get enough of a good thing. Bad idea, you need middle molecule clearance that comes from the day dwell. Number 3, bad idea, you'll need the day dwell eventually, so get used to it, suck it up and do it now. Or number 4, it's a good idea, go day dry. Well, I presented this in a loaded manner, and I think you'll guess that I think the right answer is number 4. I don't believe number 1. We don't just live to dialyze, and you can get too much dialysis, and our patients tell us that all the time with both modalities. Middle molecules from dialysis clearance are not important in somebody who's got as much residual function as this lady has. And I think the attitude that says, suck it up now, you'll need it eventually, is also misleading. Many people don't ever need it or get transplanted first or whatever. So good idea, go day dry. This is incremental cycler PD. It's a common prescription in APD, and we very often use it at the start when people are initiating PD, and when they often have a lot of residual function. There are many other incremental prescriptions, and you know these, I'm sure. The CAPD doesn't have to be 4 bags a day. It can be 3, or it can even be 2 with sometimes perhaps icodextrin for 1 or even both of those, quite commonly done, especially in people with fluid overload issues. There are other prescriptions listed here. Sometimes we would go with lower dwell volumes. Many cycler patients, they're the majority nowadays in PD, many of them like a day off, a night off, I should say, perhaps at the weekend. And many of them would be happy to do 6 hours or 5 hours even instead of 8 or 9. So I think there's a huge variety of options here that people might use that fit under incremental. And in the recent ISPD guidelines, there's an article on this that I was a co-author on. And we came up with the definition, and I'll quickly mention that. It's 3 requirements to call something incremental PD. One is that they're on a prescription that's less than the standard being 4 2-liters for CAPD, and typically about 8 liters for an at least 1 day dwell for APD. The second feature of it is that the peritoneal clearance alone will be less than the goal, which might be 1.7, might be something else nowadays. But the total clearance is greater than the goal. In other words, residual renal is putting the person over the top and giving them the clearance. And the third critical point is that there's a clear intention to intervene and increase peritoneal clearance if and when clearance falls below the goal. The rationale is that if 1.7 is good enough due to PD alone, it's surely good enough if it's due to a combination of both residual and peritoneal, giving you that 1.7. The advantages are obvious: less work for the person on PD or their caregivers. In other words, more of what patients say they want in that SONG PD review: life participation. Also, less exposure to glucose, less mechanical stress on patients, lower cost for the patients, and many never require the full PD prescription. And bottom line is that they eventually get transplanted, or they move to HD, or even pass away for some other reason without ever needing the full prescription. And you have made their life that bit easier on PD. Patient-centered approach is the essence of all this. There's very many types of incremental prescriptions, and I've suggested that the patient can look at choosing between them and finding the one that suits them best in association with you. And I think nurses are much better than doctors at this. Many doctors don't quite get it about these different prescriptions, and nurses are often much more aware, not always, but much more aware often of the patient's lifestyle challenges. The downside of incremental PD is you need to keep an eye on kidney function. Residual renal function, we say every 3 to 6 months. Most units actually collect urine and measure it. Some take a slightly more relaxed approach and use clinical judgment or urine volume estimates or even symptoms. Not always reliable, but it's another option. It is, of course, sometimes difficult to increase the prescription when someone has got used to the incremental approach, like adding a day dwell if you haven't had one. But I still think it's the right thing to do. I think it takes the patient's life situation and makes life easier for them. It takes it into account. There isn't a big randomized trial showing this works, that it makes people live longer. There is one randomized trial now from China showing less peritonitis with incremental CAPD, less procedures. But there is many observational studies and absolutely no sign of any worrisome signal that it does any harm to patients. And remember all the time, it makes life easier for them and their caregivers. Bear in mind that you can keep it going longer by protecting residual renal function. Be careful about volume depleting your PD patients. We sometimes do it with too much enthusiasm, and you know about contrast and aminoglycosides. And on the other level, we know that ACEs and ARBs protect renal function just as they do in people who are not on dialysis. Let's take another case. This is an older man, 86 years old, diabetes. He's on day dry cycler for the past 18 months. He's losing his urine output. So somebody was taking an incremental approach here, and the KT&V has fallen, and you don't think he's as well. He's not eating so well. His energy is mediocre. On the other hand, you're mindful he's 86, and many of the symptoms of uremia are not so different from the symptoms of frailty and old age. But you're an enthusiastic doctor or nurse, and you add a 2-liter day dwell, and you've all seen the movie here. He complains of being distended and uncomfortable, and he says, "Doc or nurse, thank you very much, but you've made my appetite worse, not better, by putting this fluid in me all day long." So you say, well, let's try 1.5 liters, but he's still uncomfortable. And he says, I still don't feel as well as the way I was before. What are your options? So here's 4 or 5 options. Try 1 liter next. How about 1.5 liters for 4 hours only? Maybe as a last bag option, just for 4 hours, or even as an evening dwell before you go on the cycler. Or maybe go back to being day dry, but push them up to 15 liters and see if you can get more clearance that way. Or just say, go back to the 10-liter day dry prescription. And how are you going to decide? Well, I think 10 years ago, you might have followed KT&V a bit more religiously, and B, you might have said, well, I know best and I'll decide. But I think nowadays the answer is you talk to the patient. You might talk to their family. These are some of the prescriptions just visually that I was talking about, short day dwells and so on. But the key point in this case to me is this man is 86. If you look at and I'm very mindful, everyone is different, but on average, survival in ESKD at 86 years of age is not long. He'll be doing very well to live 2 more years. And it sounds like he's on a little bit of a downward trajectory. His dialysis is about quality as well as quantity of life. And even if quantity of life matters most, the evidence for the survival benefit, as I pointed out to you earlier, of higher clearance is suggestive at best and not conclusive. So this is a case where you would look at his goals with him, perhaps with his family if they could help you and help him, and make a shared decision. And in this case, we talked about all of this, we consulted with them, and we ended up going back to the original 10-liter prescription. That might seem a very timid, conservative decision, but I actually think that's a brave decision and the right thing to do sometimes in a case like this. Let's try another one. This is an 80-year-old woman with diabetes who's on a sort of a complicated prescription where she cycles not so much at nighttime, just three dwells, but she has a 2-liter last bag fill, 2-liter day dwell. And then each evening she goes on a 2-liter day dwell before she goes back in the cycler. What Fresenius used to call PD plus, or what Baxter might call high dose or whatever. This prescription's quite common, but this lady is struggling. She's been on PD for 2 years. She's got worsening heart failure. Her blood pressure has gone low. Her health is deteriorating, and often the hardest thing, she's losing both her vision and her hearing. This lady, you've seen this before. She has the dwindles, as we sometimes say. Her quality of life is poor. She's finding the whole PD hard. She has some help with it, but this is a lot of procedures and hooking up to things and so on. So she wants to, so you discuss this with her, and you say, have you thought of letting go here and stopping the dialysis? Has it reached a point where the quality of life is unbearable? And she says to you, oh, yeah, maybe, doc, I have, but my husband and my 2 daughters would be very upset. Sometimes people say this because they mean the husband and the 2 daughters would be very upset. Sometimes I think they say it because they're just not ready themselves. That's her choice and her right to have that point of view. So she doesn't want to stop. It's a big decision for many people, for anybody. But could she have less dialysis and skip a few days a week, she says. And again, this is something that might have been heresy a few years ago, but now is becoming much more widely accepted. And this is the idea, sometimes called palliative or low intensity dialysis, where you ignore clearance targets. You don't worry so much about volume. You concentrate on symptom burden and quality of life. It's goal-directed dialysis, in this case, goal-directed PD. It's an alternative to stopping dialysis for those who are not quite ready, are not quite able to stop. And in this case, it can be an ethical issue. Some people are uncomfortable with it. They say it's death by under-dialysis. But I would submit that a person like this is slowly dying anyway, and you're trying to make the whole process easier for them. So the decision made in this case was continue on the cycler, give her 1 night and 1 day, therefore off a week, stop all the day dwells. Well, there was a 1-liter day dwell left in, but not 2 anymore. And she did fade away and died. And I'm not sure the dialysis prescription made any difference, but there was a sense that the focus was completely on her comfort. And it's an alternative from stopping altogether. Some people would say stop altogether, but this one I find is often a bridge to stopping altogether or a substitute for it in people who just can't cope. I've done it in hemodialysis too. People with terminal diseases who don't want to stop, go down to twice a week, stop trying to take too much fluid off within reason. You don't want the person to go into pulmonary edema either. Here's another case. This is a very different end of the spectrum. This is somebody who's in line for a transplant. He's 60 years old. He weighs 90 kilos. He's on a cycler prescription. And after 6 months on PD, his weight is up 10 kilos. And this happens, we see often in the first 6 months on dialysis, people gaining quite a lot of body weight. Transplant team, in their wisdom, say, I'm not going to list this man until he loses 10 kilos. I think that was more common again 10 years ago. It still happens a bit, I think, but they're not quite as ruthless about it as they sometimes used to be. I think they're accepting again a little bit more flexibility on this one. But still, it's often a big issue for patients. They've got to lose weight to get listed. So how do we approach this? This is a patient whose goal is not KT and V, it's get me on that transplant list. First thing you've got to work out when you deal with these cases is it fluid or is it fat? Not always easy to tell, often a mix of both. And I think you have to recognize in the early months on PD, but also on hemo, there is a tendency to gain weight. So in the first 6 months, if somebody's gaining weight, it's not usually fluid. It can be, but it's not usually. I would tend to put the money more on their gaining body weight because they're on that honeymoon period where they maybe are feeling better after maybe a year of uremia, and they're starting to have a better appetite and eat more. This is a graph I often go by. I think it's very helpful. It shows the course of the body mass index, but think of it as the weight on average in people on dialysis. And right at the beginning of dialysis, the first couple of weeks, people lose weight. And of course, that weight they're losing, whether it's hemo or PD, is typically fluid. These people are mostly fluid overloaded on the day they start dialysis, and the weight comes down often quite dramatically. And then in the next 6 to 12 months, there's a period where weight rises. And that's the same on hemo, and it happens on PD as well, as you can see here. It's pretty unique. And sometime around 1 year, it starts to flatten out. And for a few years, it stays around the same. And then on average, unfortunately, in many of our patients, in the period between 2, 3, and 5, 6 years, they fade a bit. They start to waste away. And many of them are older people. This happens. This is an average. Again, there are lots of younger patients who don't follow this. But it's good to keep it in mind. Early weight gain on dialysis is often regaining body weight you'd lost before you started dialysis. And that's hard to stop that happening. In a way, it's a good sign. But unfortunately, for some people, it gets them into trouble in terms of being overweight and being acceptable for transplant. So the first lesson, I guess, is don't presume it's fluid. Don't go trying to dialyze their increased fat and maybe muscle, let's hope too, off them. Sometimes you're looking at obesity or effects of medications or so on. I also say don't think that everybody who's breathless is fluid overloaded. Deconditioning is much more common than pulmonary edema. High blood pressure is not always a great index either. You have to work out if it's fluid or not. There isn't a simple test. It's trial and error, but remember the time frame and obviously examine the patients. But often on hemo and PD, you will try and see what happens. And that's a start. How do you stop this weight gain in the first place? Or when it happens, how do you stop it? Well, we have in PD what we call glucose sparing strategies. And then we have lifestyle changes. The lifestyle changes are more difficult, as you know. Diet and exercise. Exercise can be challenging, but it does work if people can do it on dialysis. Diet can be challenging too. But the glucose sparing strategies you know about can be divided into those that substitute non-glucose solutions for glucose and those that reduce the need for glucose. Reducing the need for glucose, salt and water restriction, high-dose diuretics like furosemide, even metolazone, ACEs and ARBs to preserve kidney function, incremental PD. If you don't have a day dwell, especially a glucose day dwell, you will be less likely to put on weight. Improved glycemic control, realistic target weight, try and stay away from the 4% bags. These are all methods of reducing the need for hypertonic glucose, and that will help you to avoid some of the weight gain that happens in the first 6 months in many dialysis patients. Non-glucose solutions can be used. We used to talk about amino acids. They've faded away. They're hardly available anymore. Icodextrin is glucose sparing, and it does lead to less weight gain. And we often, in the people who are really in trouble with this, use 2 icodextrin dwells and less hypertonic glucose as a result. Best to be glucose sparing from the start in people who look like they're at risk of gaining weight, who have a history of being overweight. Very rarely a switch to HD, I think, is necessary. Some people just really put on the weight on PD Generally, the same thing tends to happen on HD. Most of them will stabilize after 6-9 months with a glucose sparing approach, but it can be a challenge. The last case I want to cover is a potassium case, and we see this one reasonably often on PD as well. Renal failure, you think of high potassium, but we see low potassiums in about 10% of PD patients. 64-year-old woman with diabetes, and this is her blood work. Her potassium is 3. The dietitian comes and liberalizes potassium intake, but some people just don't eat a lot, and especially when they're on dialysis, and the potassium is hardly budged 4 weeks later. What's going on? So some of the things that contribute are the low potassium diets that people are on CKD, but some of them have poor nutritional intake anyway. Furosemide and metolazone are used in dialysis patients to avoid weight gain, or fluid gains, I should say. They lower the potassium. There's some evidence that glucose loading, as occurs in PD, can do it as well because of the insulin effect it induces. So what's my clinical response? Well, I'm giving some choices here. I mean, forget it. It's no harm. Doesn't affect outcome. How about a high potassium diet? You've sort of tried that already, but you can push it a bit more. Stop the furosemide. The only downside of that is sometimes the furosemide is helping with avoiding excessive volume gain. Start potassium supplements. They're a bit impalatable, but we sometimes do that. Start an ACE or an ARB. There's other reasons to use those if the patient is not already taking them. So a couple of quick points. Why do we treat low potassium? We should treat it. There is evidence that it predisposes to peritonitis, perhaps because it makes your bowel less mobile. It's associated with cardiac death. And interestingly, it's associated with infectious mortality. So this is something that you do need to try and correct, and it isn't that hard to correct usually. There are a number of big studies done in huge databases in recent years. I won't belabor the point, but they show that just like high potassium can be associated with worse outcomes, so can low potassium. And indeed, in PD, there is a significant issue with higher mortality on people with low potassium. Now, is it really the low potassium that causes the mortality, or is it a marker just of somebody who's struggling and eating poorly? This is a mortality diagram. It shows the increased mortality both with high potassium and with low potassium, and it's best to be right in the middle. And we're never sure, as I say, is it direct causation or association with poor nutrition? A big study from Brazil looked at this and used a thing called propensity scores to try and work that out. And they concluded that it was more than an association. It was a suggestion of causation. And so I think there is an onus on us to go after this. And I'm going to suggest something that you can do. You may be doing it already. Instead of giving people potassium supplements, is to use spironolactone. There's some trials showing that this is beneficial from a cardiology point of view in dialysis patients, particularly in hemodialysis, but also in a smaller study in PD. Prevents left ventricular hypertrophy, protects LV ejection fraction, things that are important to patients. And generally it's safe. This is a meta-analysis done by a Canadian group, and it gets a whole lot of systematic reviews that were done in both HD and PD, puts them all together and looks at how spironolactone works, shows, interestingly, that it protects those patients from cardiac mortality, that it reduces all-cause mortality. And while it does increase hyperkalemia, the average effect is pretty modest, 0.16, so about 0.2, which most patients can easily manage, especially the sort of person I'm describing who's got a low potassium. This is actually a good thing. So in case 4, I mean, there's a lot of things you can do here. Number 1 is take it seriously. Number 2 is sure, liberalize their diet, give them a nice high potassium, healthy diet, if they'll take it with fruit and veg and so on. An ACE and an ARB if not already taking, but remember spironolactone. Low doses in, obviously there is an issue with men and enlarged breasts and so on, but mostly at 25 mg a day, it won't be an issue. In my view, they prefer this to taking potassium supplements, which can be impalatable. So basically, to sum up my message today is when clearance goals are not being met and an increase in PD doses being considered, I think you should think about all the different options. Do shared decision-making, rediscuss the goals, individualize. Is the clearance goal really the right one for this patient? Is quality of life getting enough attention? And don't just think about KT and V, think about nutrition, potassium, high as well as low, and think about volume status and protecting kidney status, but most of all, life participation and the goals of dialysis are that they're much more than clearance. This is an opportunity to gauge your patients and share decision-making with them. Thank you for your attention.
Thank you, Dr. Blake. It does seem kind of strange that we're not giving you some applause at this point. That's what typically would happen. But please know
Naomi,
that
Naomi, it's Stephanie. Sorry to interrupt. Peter, you can just stop sharing your screen now and we'll go to questions. Thank you. Great. Thanks, Naomi.
Yeah. So I just wanted you to know, Dr. Blake, that we appreciate your thoughts and your time, even though we're not clapping. It is appreciated. So we have about 10 minutes for questions at this point in time. Just a reminder, you can, we'll try to monitor here between myself and Linda Turnbull if people have their hand raised to let you know to ask a question, to take yourself off mute and ask the question, or if you want to just put something in the chat box for questions, either way is acceptable.
I'll start asking questions if nobody else does.
All right. Well, I actually have a question for you, if that's okay.
I think that's okay, Naomi.
All right. So I've been in PD for a number of working in PD for a number of years now, but I remember at the beginning I had that beginner nurse question of, well, if icodextrin is good for 12 hours, why don't we just do back-to-back icodextrin, like 2 exchanges of icodextrin? And I was always told, no, we can't do that. But I never really was given an acceptable answer for that. What is the rationale for not doing just 2 exchanges of 7.5% a day?
Well, there's 2 rationales. One is that it was never approved by any of the health authorities. The company that marketed icodextrin, Baxter, never sought to get it approved for 2 treatments. So that was number 1. That doesn't mean, of course, that in practice, doctors and nurses can't do it. There's lots of medications across all of healthcare that we use for indications that are not approved. Gabapentin, many of you will know, is a medication every second kidney patient is on for about 100 reasons, most of which are not formally approved. So that does happen. So icodextrin was never formally approved for 2 dwells. Why would there even be a doubt? Because icodextrin is associated with high levels of a thing called maltose in your blood. When I say high, normally we have none, are minimal. But when you use icodextrin, the maltose level in your blood goes up because one of the metabolites of icodextrin. And people were uncertain what that might do to humans having a high maltose level. So long-term follow-up with one dwell of icodextrin didn't show any harm. Nobody got some horrible storage disease from icodextrin. People have used it for 25 years now and no harm has come. So then people, of course, push the envelope and try 2, and the maltose level goes a bit higher, but there's still no sign of any significant disease or any significant adverse consequence coming from using 2 icodextrin. Some people might get a bit volume depleted with 2, but especially older people who don't drink very much. But really, there's nothing to stop you using. The biggest contraindication might be the cost. It's significantly more costly than dextrose. We sort of don't get watched that closely in Canada. Nobody at my hospital ever says, don't use a second icodextrin. The budget people will be visiting you. That just doesn't happen. And we always say, well, hemo's more expensive anyway, if they do say that. But so I would say that there is no clear reason not to do it. You may know that some people worry the serum sodium goes down a bit, but that's harmless, really. So in summary, that's and there in terms of randomized trials, there is one group that studied it, and it does help with the various things like lipids, glucose, volume management. I think there was a study from Turkey that did that, but it's used. No, I wouldn't say to a large degree. I don't know. Do you use it in your unit?
Well, we definitely use extra Neil, but I don't think we've ever had anybody do them like 2 exchanges a day, unless it's an extenuating circumstance, like maybe they're traveling or something like that, and then they'll kind of just do it for a short time period.
So you might, I mean, the place I see it most being used now is patients with fluid overload, so-called cardiorenal patients who icodextrin gets, half a liter off maybe with each dwell. So you can use 2 of them for 12 hours each and get maybe as much as a liter off sometimes. That's helpful in some patients.
It looks like there is another question here in the chat from Catherine Duff. It says, what is your low K threshold for treating? Assuming consistent results, at what level should we treat low serum potassium?
Well, I think I like to keep it in the normal range. I mean, I don't get too excited about 3.4 or 3.3, but anything less than that, I think it's the simple things first. I mean, I think the dietitian will come and liberalize the diet. That seems pretty obvious. But many of the people who have low Ks, the diet is, they're not people that have huge appetites that want to eat lots of food, in my experience. So, so I would start intervening certainly if it was persistently 3.3 or less. But even at 3.4, you might say to them, have a banana, have some orange juice. What do you like? Is there something you'd really like to eat? The frustrating thing is that the people who want to eat something with potassium in it already have a potassium of 5.5, and the ones who don't want to are down at 3.3. But that's not always the case. So yeah, I would intervene, but I try to avoid the slow K and the potassium supplements, which are often a bit impalatable. And I find spironolactone, very few people complain about it. There is a big trial being done on it, a proper randomized trial in hemo mainly, I think, but it hasn't reported yet. Whether it really is as good as those studies suggest at improving cardiac outcomes, quite apart from your potassium level.
There is a question in the chat, just wondering why Nutrinil is no longer used from a gluten perspective. Might be extra than.
What? Nutrinil has, it seems to not be around anymore. I think the company that make it, Baxter, basically stopped. I doubt if it was making any money for them to make it. It was not worth the effort. I mean, a lot of these supplements and things, I don't know how much they really work. It sounded like a great idea. Intraperitoneal, it's like intradialytic parenteral nutrition on hemo. If people aren't eating, there's usually a more fundamental reason than they're not getting enough food. It's usually due to, in our society, usually, not always, due to wasting. The uremia is a wasting state, and they have other wasting conditions. And even if you put a few more calories and amino acids in, it doesn't always change the outlook. So I think there's been a bit of a disappointment with it. It was a simple approach, but there was never great studies showing it was very effective. And I think the enthusiasm for it just died out.
It doesn't look like there's any further questions. And it looks like we're at our time here anyway, so that's good timing. We're joined now by Dr. Jeff Perl, and he is going to be sharing with us today. Just as an introduction, Dr. Jeff Perl is a staff nephrologist at St. Michael's Hospital in Toronto and associate professor of medicine at the University of Toronto. He received his Master of Science in Epidemiology from the Harvard School for Public Health. He is a prior recipient of the John Mayer Young Investigator Award by the International Society for Peritoneal Dialysis and has received several teaching awards at the University of Toronto and St. Michael's Hospital. He serves as the current editor-in-chief of Peritoneal Dialysis International. He is also chair of the Home Dialysis Subcommittee of the American Society of Nephrology COVID-19 Response Team. His primary research interests and clinical practice focuses on improving the survival and quality of life for patients on home dialysis. Dr. Perl is a primary investigator in the International Peritoneal Dialysis Outcomes and Practice Pattern Study and principal investigator of the Optimizing the Prevention of Peritoneal Dialysis Associated Peritonitis in the United States study. He also, I believe, is an Iron Chef for the International Society of Peritoneal Dialysis. I believe I bandaged his finger a time or two as he chopped himself a couple of, or at least once. So Dr. Perl today is going to talk about unusual PD complications. And I know all of us who are PD nurses or other healthcare providers can think of one or two rare situations that have caught us off guard or forced us to do some creative problem solving. So Dr. Perl is going to share about that today. Go ahead, Dr. Perl.
Thank you. And thank you so much for the invitation. It's really great to be here. I just want to say, first of all, that my heart goes out to what you guys are experiencing right now as a result of the mudslides and the bad weather. And, you know, looks like it's not behind you from what I can see from Environment Canada. So I just want to say our thoughts are with all of you guys and everybody affected. And hope that, you know, things turn a corner. As if COVID wasn't bad enough, you know, this is sort of being hit when you're already down. But on a happier note, thank you for reminding me, Naomi, about my embarrassing stint as Iron Chef. I just want you to know that I am a foodie and I do cook very well. And actually, I'm giving this talk in my bedroom right now. And I'll just tell you a funny anecdote before we start the presentation. So that knife was so dull. And, you know, they always say with a dull knife, you have the greatest risk of injuring yourself. And I was I was online this weekend, okay? And I love my knives, okay? So for $300, regular $700, I bought this whole set of knives, okay? Because these are like the best Japanese knives. And they were finally on sale at the Bay. And I was like, I'm going to grab these. And I didn't want anybody to use them. So I'm hoarding them in my bedroom for now because I just don't want them to get stuck in the dishwasher and get dull. So I actually take my knives very seriously. So moving on to our talk right now. So I'm going to talk about unusual PD complications, maybe not so unusual, but definitely not ones we see every day. And normally I really like to make this very interactive, but I think in the you know, we'll make sure we have an interactive component at the end. So case one is called Entering the Milky Way. So what's the story here? So this is a 75-year-old female who had CKD due to ischemic nephropathy, type 2 diabetes with impaired LV function, was admitted with heart failure and worsening kidney function, and the creatinine here is in American units, but it was about 400 for, let's say. PD catheter was inserted, and after 2 weeks of healing, presents to the home dialysis clinic for evaluation. And this is what you see when you first do a flush and drain the patient. All right, so what is this? I just want you guys to take a minute to think about what you think this might be and what are you going to do about it? All right, just to have a thought. And I'm just seeing if and people feel free to throw stuff in the chat. I'm going to try my best to have a look at that. It's a little bit hard when you're giving a talk at the same time. And so let's just think about what that could be. So you get the call, and then the next question is, what would you do next in response to that? So what we wanted to do is, this looks like it may be, if we go back, it looks like it may be, I'm having some trouble here with let's see. Okay. If we go back, it looks like a lot of people might think that this is lymphatic fluid or chyle, and this might be something called a chyloperitoneum. And what a chyloperitoneum is we'll talk about in a minute, but one of the ways that you can demonstrate that actually this is lymphatic fluid is to measure a triglyceride level in the PD fluid. And if the triglyceride level is higher than the triglyceride in the PD fluid is higher than the triglyceride level in the blood, then you've got your diagnosis. So it's really interesting. The first day that I was called, I said, let's do a triglyceride in the PD fluid and let's compare it to the triglyceride in the blood. And unfortunately, one in the blood was missed that day. And then I said, okay, well, let's do it the next day. But guess what? The next day, the nurse went to fill the patient and drain the patient, and it was pretty normal. And the triglyceride level was pretty normal. Then the next day, it happened over again. And then we were able to finally on that day get both a triglyceride level in the PD fluid and a triglyceride level in the blood. And you can see here that the level in the fluid is almost about 10 times higher than that in the blood. So it's chyloperitoneum. It's a very rare complication of PD. And what it is it's disruption to the lymphatic system in the peritoneal cavity. And what you can think about, if you want to think about the lymphatic system, think about a little drain in your, think about a bathtub drain. When we put PD fluid in anybody, yes, some of it is getting UF'd from the blood to the patient. And if the glucose is left long enough, then the gradient is lost and the fluid moves across the peritoneal membrane. But there's actually lymphatic fluid absorption happening all the time. It's about 10 to 20 mils per exchange, so very little. But everybody has the lymphatics in their peritoneal cavity absorbing some of that fluid. So I think about it like a little drain in the peritoneal cavity that's always draining and absorbing some fluid. And so the way you can make a diagnosis of this is, if you ever see this, measure the triglycerides in the PD fluid, and it should be greater than the serum triglycerides, because most of lymph actually is the way in which our body absorbs fat. Most of our body absorbs fat through the lymphatic system. And if you're damaging the lymphatic system, all that fat that should get absorbed is ending up in the peritoneal cavity. And some people have suggested if the absolute level is really high, as it was in this case, over 2.26, that might be enough. But of course, this is a rare occurrence, so there's no consensus definition. But I'd say you'd be pretty good with the triglycerides in the fluid being higher than the serum. This is Nephro Nikki. Nephro Nikki was our home dialysis fellow, actually trained at UBC, Nicola Matthews. And we had a patient who had a hemoperitoneum plus chyloperitoneum. And so this is actually, it doesn't quite look like hemoperitoneum, right? It has a sort of strawberry-ish color to it. So this is actually chylohemoperitoneum. And again, we'll talk about why those two might happen together. So the differential diagnosis is pretty broad. Anything that disrupts the lymphatic system, like intra-abdominal malignancies, lymphoma, TB can invade the lymphatic system, autoimmune diseases like sarcoidosis, rarely with cirrhosis and pancreatitis, and conditions like constrictive pericarditis. In the old days, some of the older calcium channel blockers led to chyloperitoneum, but not so much with the newer calcium channel blockers. But probably the most common cause that we see is intra-abdominal trauma. So it's been described after AAA repair and also after PD catheter insertion. And it probably will be more likely after a percutaneous PD catheter insertion, where the operator has put in the catheter blindly without visualizing the peritoneal cavity, compared to a laparoscopic catheter insertion, where there will be direct visualization of placement of the catheter. So step one is make sure it is a chyloperitoneum, which we've done already. Step two is look for the underlying cause. So you want to do a PD fluid cell count. You want to do cytology. If in the right patient, if your index of suspicion is high for TB, consider AFP or peritoneal biopsy to rule out TB. I think everybody with chyloperitoneum should get a CT scan. And if you're really worried about lymphoma, you may want to pursue a diagnosis of lymphoma. In our patient, this was very short after PD training. The catheter had just been inserted and our index of suspicion was very high that this was injury after peritoneal catheter insertion. And the management of chyloperitoneum is actually dietary. And so I don't know if any dietitians are on the call, but you guys are the star of the show when it comes to management of chyloperitoneum here. So all lymphatic flow, if we eat a big fatty meal, we're going to increase our lymphatic flow because that's how the fat's going to get absorbed. And so the long chain triglycerides are converted into monoglycerides and free fatty acids, which are transported as chylomicrons in the lymph ducts. So if you're going to eat long chain triglycerides, it's going to get converted into free fatty acids and transported as chylomicrons. Medium chain triglycerides don't have any lymphatic absorption. They get directly absorbed in the portal vein. So if you told somebody don't eat any fat, they'd run into issues related to fat, deficiencies related to fat and fat soluble vitamins. So you can't tell people to restrict fat, but what you can do is say restrict fat, and any fat intake you do take, enrich your diet with things that have medium chain triglycerides. And I forgot what type of oils and what type of diet you can advise your patients to take, but definitely our dietitians are well versed on what are medium chain triglyceride fats versus long chain triglycerides fats. So, that might be coconut or palm oil or nutritional supplement. So you want to make sure that patients start with a low fat diet and then go to only medium chain triglycerides. And in most of the time, it goes away by itself. So, you don't have to really be too worried about this, because if it's related to injury of the PD catheter, it should heal over time. Very, very rarely these patients need bowel rest or TPN, but in most cases it goes away on its own. And if it does need a little bit help, octreotide is a drug that can help reduce intestinal fat absorption and was used in 2 case reports with success. So back to our patient, we had no identifiable cause on the workup. We did the CT scan, the cell count, we made sure that there was no lymphoma, and it was felt due to PD access insertion. We put the patient on a low-fat, medium-chain supplemented diet, and the chyloperitoneum resolved, and she did PD for quite a long time without any incident. Now, the question is, why do I have the fries and hamburger on the slide here? So it turns out that the next day, the patient came when we had resolution of the chyloperitoneum. She hadn't really eaten much that day. But in training, one of the nights, she decided she was going to go to Burger King and have a Whopper and fries. So the next time she came back, it was a post-Whopper and fries chyloperitoneum. And that's when we were able to make the diagnosis the second time. So it's something that, if you see it one day and the next day you don't, it's very much going to be related to what the patient has taken in terms of the fat content of the diet that day. So that's chyloperitoneum. The second case is called scrotal recall, which now I'm been told is a Netflix show, but I just want people to know I came up with this name before Netflix. So this is a 70-year-old male, had CKD due to diabetic nephropathy, had ongoing pancytopenias with 2 normal bone marrow biopsies, and in June of 2014 had an embedded laparoscopic PD catheter placed. In August, he came to hospital with volume overload. Creatinine was about 600. We exteriorized the PD catheter and started the patient on 2 liters, 3 exchanges of CAPD, sort of an incremental PD prescription. We increased the dwell volume to 2.5 liters in January of 2014. He had good residual kidney function. And in March of 2015, comes to the home dialysis unit. And he goes, "Doc, I just want to show you something." And I remember it was winter, and him and his wife were sitting there all bundled up in their winter coats, and he just drops his pants. And I said, "Oh, my." And he said, "Yeah." And then I said, "Yeah, we've got an issue." And I remember when I said, "Oh, my," because I was a bit startled with this, he looked at me, and he was a lovely man. And he said to me, his wife was sitting there, goes, "Doc, in 20 years, I've never been able to elicit a response from my wife by dropping my pants like that." So what do we think is going on right now? So this is a case of scrotal edema. Clearly, the scrotum is enlarged. Let's figure out, what would you do right now for this patient? What would be your approach to this problem? Just think about that. So can the patient do PD? Can we continue PD? What imaging tests do we want to do? Is there a definitive management for this problem? So let's work through some of these. So let's talk about PD fluid leaks. So clearly, we're suspicious that PD fluid is somewhere where it shouldn't be. That's what a leak is. It's PD fluid going anywhere except remaining in the peritoneal cavity. And that might be along the tunnel of the catheter, which we call pericatheter. And it may be in the genitalia or the abdominal wall. And the big difference when we see genital edema, like in this case, is it hernia related or not hernia related? Fluid can go in the retroperitoneum, and also fluid can go in the pleural space. And I just want to show you, this is a pericatheter leak in a patient we had with a presternal catheter. Take a look at all that PD fluid tracking along the tunnel. So this is what a pericatheter leak looks like in someone with a two-piece presternal catheter. When we talk about genital edema, it could be that all this fluid is sort of tracking down into the genitalia from a subcutaneous leak, but it also could be from an indirect hernia. And it may be that the peritoneal cavity has a hole where the scrotal sac is, where fluid is actually going directly communicating from the peritoneal cavity to the scrotum. And that's what we want to figure out here. And the hole is called a processus vaginalis. Here's what the hole looks like in men. Here's what the hole looks like in women. And in some people, even after birth, it remains open. If bowel goes into these, we call those inguinal hernias. Fluid can go in there, fat can go in there. And so patients who have a patent processus vaginalis may be at risk for hernias on PD of bowel going in here, and may be at risk for scrotal leaks, or both happening at the same time. And one of the advantages of advanced laparoscopic catheter placement, where the surgeon goes in with a laparoscope, is that they can see these and they can identify them. And we know if they're at-risk patients, and even better, they sometimes can fix these at the time of catheter insertion. So to diagnose this, you really need to do a CT scan with IP dye. You put PD fluid in with dye, usually 200 mils of, we use, I think, Visipaque or Omnipaque. You let the fluid sit in the peritoneal cavity, and you look to see if that dye ends up in a spot where it shouldn't be. And then you've got your diagnosis that there's communication. So this was our patient's CT scan, just to show you what dye looks like here. It makes the PD fluid a very bright color. You can already see on this slice of the CT scan that there's PD fluid in the inguinal canal. And again, you can see a rim here of a left scrotal edema here, again with PD fluid in the scrotal sac here, and PD fluid over here, but much more pronounced on the left side. So we've got our diagnosis. PD fluid is tracking into the scrotum from the peritoneal cavity. And so one of the things you want to do is you want to offload the pressure of the PD fluid in propagating this. So CAPD is going to increase intraperitoneal pressure a lot more than lie flat, day dry APD. So one step we did is switch the patient from CAPD to APD, lower dialysate night volumes and day dry. And I just want to show you that if you increase PD fluid volume, in all positions, you increase intraperitoneal pressure, but the worst position to be in is sitting and standing. For supine, for many of our non-infectious mechanical complications of PD, the position you want to be in is lie flat, because even if you increase the dialysate volume, the pressures are going to be a lot lower transmitted to the peritoneal cavity. And this was simply the effect of 4 weeks of NIPD. And you could say, okay, well, let's stop here. But you know, this patient might lose residual kidney function. They may need a day exchange down the road. So it's probably best to have a definitive solution so you don't run into the problem again the minute you start to add a day exchange. So you want to refer the patient for surgical repair. And we sent the patient to a surgeon, and the surgeon told us that we should put the patient on hemo while we arrange for the repair. But I want to point out, and here's another important teaching point, not all patients going for hernia repair need to be transitioned from PD to hemo. It is possible to do bridging hemo. So I told the surgeon, let's try do some bridging PD. We did NIPD, which was already successful. And the way in which we managed this is we held PD for 4 days after the hernia repair, and then reintroduced PD day dry for 2 months, and then gradually increased the PD prescription with a wet day. And I just want to point out that if you're thinking about, and I'm always happy if people want to reach out to me after the lecture or at some point if this comes up in your program, if you look at the protocol for continued PD after hernia repair, there's been a couple of case reports and series, one from Toronto, one from Dr. Crabtree, just saying again, if they can tolerate it, you hold dialysis for 48 hours, you start low volume cycler day dry for a period of 2 weeks. And then gradually over time, you can increase the fill volumes and convert the patient back to CAPD after about 4 to 5 weeks. So who would I consider a candidate for bridging hemodialysis versus can continue with PD? If our surgeon tells us that the mesh is going to be extraperitoneal, that they're going to use to repair the hernia, they're going to use a mesh to make sure that the hernia is well healed and well managed so that the doesn't come back again. If the mesh is exposed to the peritoneum, that could be a risk for infection. So I always ask the surgeon, is the mesh pre-peritoneal or is it exposed to the peritoneum? If it's exposed to the peritoneum, I would put the patient on hemo until the mesh actually develops a peritoneal membrane around it. It takes a few weeks for that. The second thing is, does the patient have enough residual kidney function to cruise them through the problem without needing bridging hemodialysis? And again, now this patient could tolerate 48 hours off PD. If they have a lot of residual kidney function, we have patients that, stay a week off PD. So the 48 hours isn't a hard and fast rule. It's just something that you can think about, but you can certainly go longer. That's the minimum. Now we have potassium binders like Lokelma or Veltassa. You could consider using them at this point if your patient has struggled with hyperkalemia in the past. So I think it's even more possible now than it ever has been before. So that's exactly what we did. So again, you can do temporary, you can do low volume PD. You don't always have to put the patient on temporary hemo. Ask about the mesh and find out if they have enough residual kidney function. And that's why if you see a hernia, ideally hernias are to be repaired before PD, and you should screen for them in your CKD clinics and potential sources of leak. But even if you notice them when patients first start PD, they're probably best corrected early on rather than waiting for it to be a problem later on. Okay, this is another case. Dr. Perl ruins our Florida vacation. So this is, again, all true stories. 65-year-old retired police officer, has polycystic kidney disease, does hemo until 1996, and then in 2013 had progressive graft failure. Also had a hematologic condition that was in remission, was referred to our clinic. We inserted the PD catheter and initiated PD due to symptoms of nausea and vomiting at a GFR of 5 with a urine output of 1.5 liters per day. He starts NIPD, 2 liters, 5 cycles over 9 hours, gets much better, feels so good, and he books a trip to Florida for the winter. 3 weeks before the trip, he calls the PD unit with shortness of breath. And of course, what's the knee-jerk reaction? Volume overload, increase the concentration of glucose on the cycler, and we started the patient on a diuretic. 2 weeks before the trip, still says, I'm not getting better, I'm still short of breath. The UFs on the cycler are good. At that point, was told to start a daytime exchange. And again, I finally met him 1 week before the trip, and he says, I've been dealing with this really bad shortness of breath. They've been trying to get me to remove more fluid. He was sitting well on room air, but what would you do now? Think about what you would do now. And what we decided to do was a chest x-ray and take a look at all this fluid in the pleural space. So we think this is a special kind of leak called a PD hydrothorax or a pleural peritoneal communication. So that's a communication of the PD fluid between the cavity and the pleural space. It's about 1 to 2% of all cases of PD. And it's something that you're going to see early on when patient starts PD. It's very unlikely to happen in a long-term patient. It's something that'll present usually in the first 3 or 4 months. PKD might be a risk factor because of increased intra-abdominal pressure. And patients will present with shortness of breath, weight gain. They may present with diminished PD effluent. And of course, the hallmark is a chest x-ray that shows a very large unilateral pleural effusion. And 90% are right-sided. Remember, that's an important factoid. 90% of these are right-sided, and usually after patients start PD. And, you know, we think that some people are born with these little defects in the diaphragm, these blebs, and the PD fluid can, again, track through here between the PD cavity and the pleural space. And this is actually a picture that my thoracic surgeon provided to me, where you can he's actually pressing on the abdominal cavity, and you see this weakness, this bleb in the diaphragm here. This is exactly what one of these looks like. And here's some PD fluid dripping in to the pleural space. So this is a communication between the pleural space and the PD cavity. So why do we think that they're more likely to happen right-sided? We think that people have a porous or congenital diaphragm, which would never cause a problem if there was no fluid in the abdomen. The intestinal circulation sweeps it up to the right upper quadrant, and in the right is where the liver is. And as people breathe, the liver is moving up and down and kind of acts as a piston, forcing fluid on the right. So even though the blebs and stuff may be on the right and the left, there's a pressure situation on the right that makes it more common there, or that's the theory. Never diagnose this by putting methylene blue either in the pleural space or in the peritoneal space and looking to see if it pops up. A, you're putting such a small amount, you may not be able to see it. B, it can cause a chemical peritonitis. The best way to diagnose this is to actually sample the fluid. And if it's a sweet effusion, if it's filled with PD fluid, you got your diagnosis. The glucose in the pleural space will be higher than the blood, and you know that a glucose-rich fluid has entered into the pleural space. The problem is that glucose gets absorbed across the pleural space, and so in many cases, you're surprised because the glucose in that pleural fluid, when you do a thoracentesis, is normal, particularly if it's been long-standing. And so a peritoneal study, a CT scan with IP dye or a nuclear scan can sometimes give your diagnosis. You put dye in the pleural space, in the PD cavity, and you take some images and wait to see if the dye ends up in the pleural space. But these are very small leaks that present over weeks. And in my experience, don't be surprised if these tests are negative. The longer you leave the fluid in the peritoneal cavity, the better the yield, but oftentimes you get a negative result. So it can be very unsatisfying when you have a patient with a large pleural effusion. You know it's got to be a pleuroperitoneal communication. You've done your thoracentesis, the glucose is normal. You've done your CT scan with IP dye, you can't find it. And then you're like, well, how do I demonstrate that it's there? So let me show you one more thing that we kind of experimented with at St. Michael's, some did. What we did with the last patient is we admitted the patient overnight. We put a pigtail catheter and drained all the pleural fluid. And of course, this initial glucose was negative. And again, this was what first came out. The blood glucose was 7.7. And then we said, well, let's just do their usual PD overnight. We've got the drain in place. If any fluid ends up there overnight, we'll sample it right away. So we admitted the patient, we sampled the patient overnight, and guess what? We got our diagnosis. The new fluid that came into the pleural drain had a glucose of 58. So this is just to show you the initial glucose was pretty normal, but if you do a pigtail drainage and admit the patient and do cycler, you can sometimes manifest this. And it's not the wrong thing to do because many times patients will need a pleural drain just to get comfort and symptom relief from the shortness of breath. So I think this is a great way to think about managing this. Speaking about icodextrin, and I know we were talking about icodextrin in the last talk, say someone's doing 1 ICO a day and you're worried, is this a pleural peritoneal communication? As Peter said, we use a lot of our icodextrin in our cardiorenal patients. So 1 ICO a day, new pleural effusion, is it heart failure? Is it a pleural peritoneal communication? If you add a drop of iodine to the pleural fluid, and if icodextrin is present, the starch in the icodextrin will just turn that iodine jet black. If you take a regular pleural fluid without starch in it, without the icodextrin metabolites, it'll just be an amber colored fluid. So if you're ever worried if the pleural fluid is icodextrin when you drain the patient, add a drop of iodine to it and see if it turns jet black. Then you've got your diagnosis. This is actually a patient who had a lung pleural peritoneal communication through a hiatus hernia. So fluid came in through the mediastinum into the mediastinal space. And this is a pleuroperitoneal mediastinal communication. And again, this was managed with surgical repair, which I'll talk about. So you want to demonstrate that it's a pleural peritoneal communication. When we talked about a few ways to do it, a few ways not to do it. This is not something that if you put the patient on night cycler, day dry, you're going to be able to relieve. You really have to stop PD. And they say in the textbooks that if you put somebody off PD for 6 weeks, it can sometimes heal on its own. In my experience, it's never been successful to heal on its own. And then you have a talk with the patient. You say, listen, Mr. Smith, if you're on hemo, this will never cause you a problem again, assuming he doesn't get liver disease with ascites. But if you're on hemo, won't be a problem. And some people say, thank you very much. I've given PD a shot. Not for me. Some people say, no, I want PD. I've got grandkids out west. Out east in your case. And I want to go visit them and this, that, and the other. And so, people are gung-ho about PD. And then you talk to them about the definitive management, which is surgical correction of these bloods and pleurodesis. What you use to do a pleurodesis, the thoracic surgeon will inject something in that space that will cause the lung to stick right against the wall and completely obliterate the pleural space. So there'll be no place for fluid to go. And you can use talc to do that. You can use all sorts of things. One thing has not been proven to be better than another. I would suggest that you send your patient for VATS where they can directly visualize the pleural space. And it has about a 60% success rate. The other thing is patients will have to have single lung ventilation when this is being done. So this is not somebody that's frail and elderly and with a lot of comorbidities. This would be somebody who can tolerate that. If not, some thoracic surgeons and respirologists can actually attempt a pleurodesis at the bedside. But in my experience, I don't think the result is as good. So you have that discussion with the patient, and our patient definitely wanted pleurodesis. He had a VATS with talc, stayed on hemo for 4 weeks, actually had a recurrence, had a repeat VATS with betadine as the agent, and started cycler in 2014 and had a 1-month trip to Florida thereafter, did really well on PD, and now has had a successful kidney transplant. So it can be managed with pleurodesis, either VATS or bedside. But like I said, VATS is better, but has a higher surgical risk. My last case, and I know we're a little bit short on time, is unusual peritonitis, so I'll whip through it. This was a 72-year-old who had end-stage kidney disease due to hypertension, gets a PD catheter insertion, and comes to the unit right after starting PD with cloudy fluid. And then you do your cell count, as we should in culture, and you see that the cell count is over 100, it's 236. But what's really peculiar about this is that it's not neutrophil predominant. For peritonitis, it should be greater than 50% neutrophils, but the predominant cell type here is eosinophils. So this is eosinophilic peritonitis. So what is that? So typically occurs within the first few weeks of starting PD. 57% have an accompanying peripheral blood eosinophil count. We don't know what causes it. We think it's some allergic type reaction, either to the catheter or to something, the air that people introduce when they're doing PD. But the nice thing is that it usually goes away on its own, but in some cases can smolder up to 6 months. So you want to rule out bacterial infection. And in some cases, they've had it controlled with antihistamines or a low dose of steroid therapy, but usually goes away on its own. So our patient was initially treated for peritonitis with antibiotics, had no systemic eosinophilia. The culture was negative, so we stopped antibiotics, and the cloudy fluid just went away on its own. So just something in the brand new PD patient who gets cloudy fluid, think about eosinophilic peritonitis. So that's all I had to say, and I'll stop there and see if there's any questions or comments. And thanks so much for your time.
Is chyloperitoneum dangerous, or do patients have symptoms other than cloudy effluent?
Yeah, no, it's a great question. I think that the answer there lies in what's the cause. If it's simply a damage to the lymphatic duct after the PD catheter is inserted, it usually goes away and it heals on its own. If it's due to a lymphoma or some other external factor that's damaging the lymphatic system, then I would say it might be a marker of something more ominous, which is why we should always sort of do a CAT scan, send the fluid off, make sure we've ruled out what's in the differential diagnosis of what can cause lymphatic duct injury.
I'm just sorry I asked that question. For the woman who you found that it came back after she had that fatty meal, if it doesn't resolve, like, is it bad that it's ongoing or recurring?
Oh, yeah. I mean, theoretically, with really good dietary management, it should actually resolve on its own. But yeah, I mean, over time, if it's lingering for a long period of time, I suppose it could lead to fat malabsorption and cause nutritional issues. So that would be my major concern with that.
Thank you.
Another question from the chat, just wondering if you've had experience with a catheter repetitively migrating and the patient having bad fill and drain pain on CAPD and or cycler.
So in the same person, this is the same is it two separate questions about two cases, or is this the same patient who has that problem?
The same patient.
Curious. The same patient? Yeah. So the answer is yes. I mean, let's tackle the first one. The catheter repetitively migrating, to me, speaks to a challenge with insertion, and the way in which the catheter was inserted in the peritoneal cavity must be with such a torque that the way the rectus tunneling was done, the catheter naturally wants to go where it sort of had that learned memory of elasticity. So it's going to flip up. And if that keeps happening, to me, the catheter probably should be replaced because it probably, the way in which the tunnel was created into the cavity may signify a problem. And I'll just ask that, was this catheter inserted surgically or was this catheter inserted bedside or percutaneously?
Percutaneously, and it's her second catheter that's done the same thing.
But both times inserted percutaneously?
Correct.
Yeah, so I mean, and you know, that's enough to cause anybody to say, you know, I'm done with this, because I can imagine how frustrating it is for a patient to go through that. But if they are still eager, I certainly would want to give them the benefit of an advanced laparoscopic catheter placement. The other thing is, did the drain pain happen with both times?
Yes, so when she had her first catheter inserted, she had drain pain right away. And as the catheter migrated, she also developed fill pain.
Yeah.
With the second catheter, the drain pain was there initially as well. No fill pain initially, and about a week after insertion, we started PD, and the drain pain again was still there. No fill pain. Again, as the catheter migrated, the fill pain has come back.
Yeah. So to me, there's something in the abdomen where the fluid might be pocketing, and there may be adhesions, and there may be some other reason. Remember, drain pain is when the catheter itself is sucking along the wall of the peritoneal cavity or or some abdominal organ. And so if the fluid is pocketing in different spots, that can lead to drain pain. So the whole thing to me smells of adhesions and some issue with space issues in the peritoneal cavity that I wouldn't promise the patient we could fix it with a third catheter, but I definitely would want someone to look in with a laparoscope and see exactly what the issue is and why that catheter keeps migrating and isn't going in the right place. And at least the patient and the team would have some more information by a direct visualization through a laparoscopic replacement.
I also had a question. Have you had a patient with polycystic kidney and liver develop peritonitis from like ruptured cysts in the liver? Is that a possibility?
Good question. So the cyst would have to rupture and the cyst would have to be infected. So I have personally not had that happen. I have seen liver abscesses with secondary peritonitis. More commonly, what I've seen in polycystic kidney is a ruptured cyst leading to hemoperitoneum. And usually when the cysts rupture, there's a little bit of blood that's released. So that's the more common scenario that would happen with a ruptured liver cyst rather than infection. But it's not out of the realm of possibility, for sure.
Thank you. Yeah, the interesting part was it was like a culture negative microbiology result a couple months apart, and with increased neutrophils and stuff, but no growth but cloudy fluid. So it was interesting.
And how did you know that the cyst ruptured? You had imaging that showed that?
I don't actually know for sure. I can look it up, but she just has polycystic liver and kidney, and so I was just wondering. But
yeah, and maybe there was sort of a reactive cell count, but that's really an interesting case.
Yeah, thank you.